Hello, I'm Dr. Stefan Weiss, a board-certified dermatologist, and I lead the efforts at OM1 focused on dermatology. Now, one of the things that I always confront as a clinical dermatologist in seeing patients is understanding when an individual is on a particular therapy, why it may be appropriate to change or discontinue his or her treatment. What we realized was in looking at data across the entire data set that we have within the immunologic conditions, dermatology and rheumatology specifically, we can begin to understand why physicians like me may be changing or stopping their patients' therapy and the reasons they're doing so at a macro level. And to accomplish that, we created the Reasons for Discontinuation Analytics Report. So in large part, what we're hoping to do is understand the market landscape with precision patient insights. So for instance, it's really important for life sciences companies to understand at a qualitative level why certain populations of patients may be prematurely dropping off that company's treatments or competitive therapies. And in order to understand this, we can survey real-world data to understand those discontinuation patterns and segment them by specific patient populations. We also recognize that market research of physicians is highly limited. You're getting recall bias, and you're getting a small subset of the overall population. By leveraging real-world data, we can sample upwards of 15% of any clinical specialty to understand why those physicians in particular may be stopping or changing a patient's treatment. To accomplish this, we created, as I said, a Reasons for Discontinuation report. And we do this by transforming unstructured clinical notes into categorized, actionable insights. From the clinical narrative of dermatologists and rheumatologists, we are able to read the notes to understand why a physician may have stopped a treatment. For instance, the patient may say that she is not happy while she's on the treatment because of a particular side effect, such as hair loss. There may be issues around injection site reactions, weight gain or weight loss, or frankly, the drug may not be working very well. And on the flip side, the patient and or physician may feel that remission has been achieved. Because this comes out of a large real-world data set, we are also able to categorize these individuals by certain categories such as race, ethnicity, gender, and age. And in doing so, we can look to make sure that the reasons for discontinuation of any particular therapy are not standing out within one category versus another. So when we think about discontinuation patterns across therapies, we can understand within that particular medication why individuals may be ceasing a particular therapy. We have created what we consider to be 6 large or macro categories to fully understand the problem of discontinuation. And those are lack of tolerability, lack of effectiveness, contraindication, coverage or affordability, clinical improvement, and then a final catch-all category that we term other. By looking at individual drugs, you can see within that drug what the reason for discontinuation may be. So in hypothetical drug A, what we see is that slightly more than half stopped that particular drug for a lack of tolerability. The second most common reason for stopping that drug was lack of effectiveness. Now we can contrast this with drug B, where we see almost 90% of the individuals stop it for lack of tolerability, and the second most common reason for discontinuation is contraindication. So we're really able to understand why one company's drug may be discontinued in reference to other drugs in the marketplace that are being utilized for a similar disease state. So the other thing that's important to understand is segmenting out by specific patient populations will allow us to have more precision in our messaging. So what we see here is looking at the 6 macro categories across geographic diversity. And what you'll find with drug A is that more individuals in the South are discontinuing for lack of effectiveness than in the Midwest, the Northeast, or the West. In terms of clinical improvement on drug B, we find more people are stopping because they are achieving remission in the Northeast and the West than the Midwest or the South. We can create similar dynamic representations of drug utilization and discontinuation with categories, again, such as gender, race, ethnicity, education, and income. So truly understanding, are there specific aspects of who the patients are or where the patients live that are driving differences that are meaningful in discontinuation, which allow life science companies to have greater conversations with the prescribers to ensure that the right patients are being put on the right drug at the right time. So the other aspect that we want to understand is to recognize and respond to discontinuation patterns that may be impacting the patients who are on your particular therapy. And so we may find, again, in looking at a comparison of drug A and drug B, there are certain dermatologic side effects that are driving discontinuation. So whereas drug A is causing more individuals to stop because of the development of a rash or itching, drug B is resulting in hair loss. Other aspects that could be important reasons for stopping a drug that would be different based on the therapy under investigation could be comorbidities, pregnancy, or surgeries. So as I said, these insights are available across immunology within derm and rheum, most specifically in psoriasis and atopic dermatitis in dermatology, as well as psoriatic arthritis, rheumatoid arthritis, and ankylosing spondylitis within rheumatology. This report is created in a PDF format and emailed biannually with updates accordingly. I thank you and look forward to speaking to you further on how this report can help drive the outcomes for the patients that are utilizing your drugs, your competitors' drugs, and treating the 5 diseases mentioned here. Thank you.